Nearly 1 in 4 women in their 40s and 50s in the US are prescribed SSRIs or antidepressants. Yet research shows perimenopause is a period of greatest hormonal volatility in a woman's life. Today we're confronting one of the most overlooked realities in women's health. Millions of women in their 40s and 50s are being prescribed antidepressants.
You see this rapid decline of hormone use, and what do you see? Essentially doubling of antidepressant use, of sleep meds, of anti-anxiety meds, doubling. You know, when you take away a tool that works really, really well for people, they're still going to have some of the issues and the problems that they're having, and they're going to reach for other tools.
What's often labeled as depression may actually be the brain's response to profound physiological change.
Rage is a big one, or exacerbation of anxiety and panic, like a lot. I had a patient once call them rage flashes.
Oh my gosh. Joining me today is Dr. Suzanne Gilbert, board-certified OBGYN, integrative health practitioner, author and founder of Menopause Bootcamp.
As these hormone levels are changing, declining, going way higher than they normally would, and are unpredictable, the brain is impacted in many ways. So mood is going to be impacted.
What is progesterone exactly? What is that doing in the brain?
There's more of a sedative effect and like a calming effect. When we replace progesterone, like their moods are less intense.
In this episode, we'll explore what's really happening inside the female brain during midlife, why our healthcare system keeps missing it, and how we can start redefining women's mental and neurological health for the next generation.
Women deserve to know about their bodies, and how can we live on this planet and not understand our bodily experience? I mean, that's just like basic human rights.
I'm Louisa, Nicola, and this is the Neuro Experience. Dr. Suzanne Gilbert, welcome to the podcast.
Oh, thank you so much for having me.
I mean, we've been going back and forth. It's Menopause Awareness Month, so what better time to get you in here?
Perfect.
Right?
Perfect. Love it.
So you're a board-certified OBGYN. I thought, who better to talk about this?
Yeah.
And today we're going to tackle depression, anxiety, basically mental health during midlife. And I think it's something that's often misdiagnosed but not spoken about. I think there's this fear that women feel in this moment where they don't know. You know, I've heard reports of women not feeling like themselves.
Oh, yeah. That's a term that is used in the medical literature, just so you know.
Oh, that's unbelievable.
Yeah.
And I've also heard, correct me if I'm wrong, actually, Dr. Kelly Casperson told me about this, that rage is something that is observed in women in midlife. Yeah. And that can be actually counteracted, or you can feel better from rage by taking testosterone.
I mean, Kelly is the testosterone
queen.
person, and I don't know the data the way she does. In midlife, there are a number of hormonal changes that are occurring. And in what we would now start referring to as the perimenopause, right? So the 7 to 10 years or more, depending on who you quote, leading up to that final menstrual period. It's not a predictable course. It's predictably unpredictable. So I really want to lay the foundation so people understand. So testosterone is declining. Estrogen and progesterone are fluctuating in ways that are not so smooth and predictable, like when you're menstruating. And all of these hormones, what people fail to understand, I think the public fails to understand, and maybe our colleagues aren't thinking about it this way, they all affect everything. It's a whole body experience. So that means the brain is involved. So the reason I'm kind of not answering that question is I really need people to understand that estrogen, progesterone, and testosterone, if we just talk about the impact on the brain itself, act at a number of levels, and they act globally in very complex ways, and then they interact with each other. So you can imagine as these hormone levels are changing, declining, going way higher than they normally would, and are unpredictable, the brain is impacted in many ways. So mood is going to be impacted. So I think to say that testosterone is the fix for something, I mean, I think we have to be careful of that. And I don't, Kelly is a really respected colleague and also personally a dear friend of mine. And I don't think she's saying like, hey, the solution for rage is testosterone. But she's right that there is a lot of data on hormones mediating mood. Yes, rage is a big one. What I see is a lot of new onset or exacerbation of anxiety and panic. A lot. Way more than I would have thought, like this is just observationally. I've been in practice 26 years. I've seen a lot of patients. I had a patient once call them rage flashes.
Oh my gosh.
Yeah. So rage, and I think, look, feelings are complicated.
Exactly. That's what I mean. Like, how do you know if you're not feeling rage by something that has occurred externally? Because I felt rage in my 20s,
of course,
for example.
Of course. And I don't think anybody's saying like rage is new onset rage, it's like, but I do think, I'll tell you, and I have this conversation all the time. I think what happens is a combination of things. Sort of the feelings are unroofed a little bit, like they're not so suppressed. There is this loss of resilience. But there's also this, I think we're kind of joking around and talking about the no F's to give 50s and that kind of thing. It's not just that. It's like lady people are done. They're freaking done. And now you add in their hormones are shifting and they're no longer capable of or wanting to suppress how they feel. I don't think it's one thing. I don't think it's like, oh, your progesterone is lower than it used to be and your estrogen's higher and so now you're having rage, as if it's like some hormonal issue. It's like, no, y'all suck and treat us like shit and like we don't want to deal with it anymore. And also, and FYI, we don't have as much estrogen in the same way, so we're not softening it anymore.
Yes, actually,
you.
So funny you said that, because that just reminded me of this new stat that I read about a few months ago, that a lot of divorces are occurring in the midlife transition.
Yeah.
I thought, well, that's really coincidental.
Is it though? Right.
We're going to go through everything, but just to close that loop, what I did learn in the last week was that testosterone specifically makes you more of who you are. So when you are on hormones and you are enraged, it's bringing out maybe something else that you need to be speaking about, or maybe you need to consult with somebody. So I think I want to go into that.
Yeah.
But before we do, I just want to share something with you. Nearly 1 in 4 women in their 40s and 50s in the US are prescribed SSRIs or antidepressants.
Yeah.
Yet research shows perimenopause is a period of greatest hormonal volatility in a woman's life.
Yep.
Okay, so some of the first symptoms, as we said, is the fluctuation in moods.
Right.
They go to their general practitioner maybe, and they say, I'm not feeling, and you can tell me as a physician, people go and say, I'm not feeling well, and then maybe they're prescribed an SSRI.
100,000%.
This is really happening in 2025?
Drives me crazy. So let me just say, these are all tools in the toolkit. Tools are not inherently good or bad. They are valuable for specific jobs, You can't really hammer. You could hammer in a nail with a shoe, but it's going to work better with a hammer. That's what we call it, hammering. It's not that the hammer is good or bad. The hammer is good at a certain thing. I have an amazing graphic that I'll share with you that my dear friend Heidi Flagg, who's an OBGYN in New York City, created. And it shows that in the years just preceding Women's Health Initiative being published and pulled, actually, it wasn't really published, it was pulled in, drama. So leading up to 2002, about 90 million women were on hormone replacement therapy, okay? And it's like an X. It's this dramatic, you see this rapid decline of hormone use, and what do you see? Essentially doubling of antidepressant use, doubling of sleep meds, doubling of anti-anxiety meds, doubling of pretty much all of those meds in the intervening years. And that rises. So, when you take away a tool that works really, really well for people, they're still going to have some of the issues and the problems that they're having, and they're going to reach for other tools. I think there's a story to be told there that hasn't been told completely yet. I'm not interested in promoting any kind of theories, but I think yes, you're right. And I think it's astonishing and concerning that 25% of us are being offered meds that probably a large number of us could benefit from. But a lot of those people really probably just need hormones.
But why is that? Like, what's happening in the brain itself? So what we know is that depression is a deficiency in serotonin. It's a neurotransmitter.
Look, we know that providing a serotonin reuptake inhibitor increases serotonin in the synapse.
Yeah, the presynaptic terminal.
Which does decrease symptoms. I am pretty sure, and I'm not a neuroscientist, that we've never actually proven that that's the only reason that depression happens. I mean, this is a sort of a much larger conversation, but we definitely know that that helps. Estrogen, if you just look at estrogen per se, if you're looking at estrogen rapid, unpredictable fluctuations in perimenopause, estrogen has way more global impacts on neurotransmitter production, and not just serotonin, GABA, acetylcholine. I mean, a number of them, many of them, has an impact on different levels of not only the production of the neurotransmitter, the transmission of the neurotransmitter, how the nerves are working together. So it has a really big impact on the brain. So sure, if you replace one of those neurotransmitters, that is probably going to help quite a bit. But for a lot of women, really the issue is the estrogen. It's not the serotonin, it's the estrogen, which is impacting many other more complex relationships. And I think the other thing that we see is that, for instance, women who are already on antidepressants who enter into perimenopause, often they're going to have episodic exacerbations. They're already on the medication. Now it's not working as well. What is that? Well, it's not just estrogen either. It's progesterone as well, which has, you have allopregnanolone. There's a lot of other impacts on the brain. When women have a history of a hormonally mediated mood disorder at any other time in their life, so if they had very severe premenstrual syndrome or PMDD, if they had a peripartum mood disorder, if they had anxiety or depression related to their pregnancy or postpartum, they are at such high risk for having a mood disorder resurface or get worse again at perimenopause. It's people who've had eating disorders, like all these things start to get unroofed again because the instability, and I think the instability in the brain due to these changes in the hormones, is having a really negative effect. So yes, an SSRI could be helpful, but it may not be the only thing.
You're just masking it.
Yeah, maybe.
Yeah. It's so interesting you said that. So I'm in the middle of doing a meta-analysis right now, and what we're looking at is the, hormone replacement therapy versus vasomotor symptoms without going into it, and cognitive decline. But what I found out is that whatever you are before moving into perimenopause is exasperated, meaning if you are a diabetic, type 2 diabetic, or you're insulin resistant, or you are obese, and you are 25 to 35 years old, and then you go into perimenopause, it is just exacerbated. It's like putting steroids on your already existing condition. So what you're saying is now, if somebody is in that stage, 25 to 35, and they haven't maybe seen a therapist, let's just say, or they're struggling with mental health issues, and then they go in to that perimenopause stage and they lose estrogen, that's just putting fuel on the fire.
Yeah. And again, it's not just estrogen, it's progesterone as well.
Because that's the sedative.
Yeah.
GABA.
I mean, right, exactly. It goes more to, and that's why we see a lot of women will come in with, in perimenopause and describe that their PMS, which had been like a day or two, or maybe it was like, it was annoying, but they knew that's what it is. I'm going to get my period in 3 days, so just stay away from me. It gets much more intense. It becomes much harder to control. It gets much darker. Like I mentioned earlier, now there's panic or anxiety as a part of it. So that sounds to me more like progesterone, because especially right before your cycle, right before you bleed, you have a more precipitous drop in progesterone. So it's complicated, and guess what? We don't know enough about it because we haven't been studying it.
Because women have not been studied.
Well, women haven't been studied to begin with, and then the Women's Health Initiative had like a really massive chilling effect on the capacity and the appetite to study this stuff. I'm hopeful it will change. We'll see what happens.
You know how passionately I feel about blood work. And if you care about your brain, your mood, your energy, your longevity, you cannot rely on guesswork. And there was a point a couple years ago where I realized I knew everything about my laptop data, my training data, even my sleep data, but I had no idea what's happening inside my body. And this disconnect was affecting my brain and everything else. That's when I started using Function Health and blood work as a whole. And it's the first time I've truly had a complete complete picture of over 160 different biomarkers, ranging from hormones to inflammation to thyroid panels, everything in between. Guys, you need to be getting blood work. I will not keep harping on about this. It is so clear to me that people don't get regular blood work, and it's holding you back in every area of your life. And Function is probably the best platform I've come across because they get all of your data. Once you do your blood work, they upload it into the health platform and they track it over time. So you can be tracking your blood work and your progress. If you haven't tried Function Health yet and you want to, you can get a lot of money off by signing up using code NEURO25 at checkout, or go to functionhealth.com/Louisa Nicola. Let's talk about grocery shopping, because I hit a point recently where the biggest friction in healthy eating isn't knowledge, it's logistics and time. I'm busy, you're busy, but if your fridge only has coffee and sparkling water in it, then you're not getting the best thing that your brain needs. I fell in love with online grocery shopping, specifically Thrive Market, because it takes all of the overwhelm out of grocery shopping. They vet every product for you so you don't have to do it. The ingredient filters are incredibly helpful, and my pantry staples arrive at my door without me thinking about it. So if you're getting your grocery shopping in person, you probably have a lot of time on your hands. But if you need to manage your time, if you're a mother, if you're an entrepreneur, whatever it is, go to thrivemarket.com/neuro. You'll get 30% off your first order. You'll also get a $60 gift. Guys, save time and get healthy with thrivemarket.com/neuro. So I always share a bit about myself on these podcasts, and I'm regular every 28 days, and I do experience, and I have by the way, from my early 20s, I have experienced 2 or 3 days prior to menstruating, I am very angry. It's like I need to people around me, closest to me, have the calendar, don't interfere. And it's really bad. And it's like I forget every month. Because I think it's like the end of the world.
Yeah,
and
totally.
I'm like, and it's like every month, and I'm mid-30s, I'm like, I still haven't learned my lesson. And now I'm scared.
Oh, don't be scared. Because guess what? You're going to go into the next 20 years way more educated. And honestly, the context for you culturally is going to be really, really, really different.
Yeah.
So I published a book. It'll be next week, 3 years ago, which is crazy to me. Really, nobody was really talking about this when I sold the book. And then all of a sudden the book came out, and it was like the zeitgeist had shifted and everybody was talking about it.
Yes.
So, that first pause event was then, and that's where I met Kelly and all these other people. And it has exploded. So even in the last couple of years, the conversation is happening. And what's happening is it's not just women in their 50s who are talking about it now. It's women in their 40s, women in their 30s, women in their 20s understand what it is. So you're going to head into that time of life with so much more support, understanding. I'm hopeful there'll be more data by then.
The brain is, and what happens in the brain when we start to get a decline in estrogen, progesterone, and testosterone. I'm starting to include this in the mix now as my trifecta. We don't hear about it a lot. It's all about estrogen. I'm trying to bring in testosterone, and don't even get me started on the data of genetics.
Right.
Because the ApoE, I'm an Alzheimer's disease researcher.
I know,
we won't go in there today, but let's just paint a broad overview of, estrogen in the brain. What I know is that it's neuroprotective.
Yes.
It does help immensely with the transport of glucose in and out of the cell.
Yes.
So we see a reduction of brain glucose metabolism.
Well, you've seen the
Dr. Lisa Mosconi's work.
Like you can see the color change. Yeah.
We see that in the amygdala especially, which is probably why fight or flight. What is progesterone exactly? What is that doing in the brain?
We don't know enough about it. We know that progesterone induces GABA receptors. So there's more of a sedative effect and like a calming effect. So one of the things that we know clinically is we see that when we replace progesterone, people start to sleep better, but there's also a lot of people have a little, like their moods are less intense. So it works. I've seen it work really well. I mean, anecdotally, I use it a lot in the luteal phase for, in perimenopause, when people are coming in with just all of that, the rage, the mood stuff, just the mood instability leading up to their bleed. I find it helps a lot. And that makes sense to me, right? Because we know that in the period of time where people are still ovulating, the egg quality is not as good. And so you're not going to make as much progesterone after that. You may ovulate, and you may ovulate really regularly, but you're not going to make as much progesterone because that's made in the ovary, right? The corpus luteum is there like waiting for a conception just in case. And then when it doesn't happen, that's when you shed the lining and everything goes away, right? But the corpus luteum is totally 100% responsible for, and that's the area around where the follicle, where the egg was ovulated from. That's where the progesterone's coming from. So the ovary is making progesterone, but not as much. And so the brain is missing it, And I mean, we're barely scratching the surface on what's going on with estrogen receptors and estrogen, let alone progesterone. So we know what it does, but more than that, I think it's hard to say.
Something that I don't understand. It's so interesting to me because you just spoke about, we introduced fertility a little just there.
Yeah.
What happens to women who have just born genetically with a low AMH?
Yeah.
Does this mean that they go into perimenopause earlier?
Well, AMH is definitely correlated with, here's the thing, when we draw an AMH, first of all, AMH really comes from the fertility literature.
But I just hear so many times that it's got nothing to do, like it scared people. So
what do you mean? That has nothing to do with what?
No, I mean, like it scared a lot of women.
Yeah.
Who are trying to fall pregnant. Because I've had people on here saying, I had a next to nothing AMH. My doctors told me I couldn't fall pregnant. And then at 42, they're falling pregnant naturally.
Because it's actually not a fertility predictor. AMH was developed initially as a predictor of who's going to respond better to in vitro fertilization. That is not the same thing as a fertility predictor. It's bled into common usage in this way. And actually, there is data on AMH and prediction of time of menopause, but like within 3 to 6 years. You know what I mean? This can get down a rabbit hole. It's interesting, and it's not like my full area of expertise, but like I just, I read on everything. This is where we're starting to look at like cellular functioning, mitochondrial aging.
Yes.
I know a lot of people are really interested, like, well, is there a way that we can slow this down and extend fertility? And I really don't know. I can't answer that question. I have no idea. People are interested in it. I think there are conversations going on now. I think nutritional status, which is something that we haven't really looked at enough, gut health, these are obviously playing a role. What role exactly? I think anybody who says to you that they, with certainty, this is, really?
Yeah.
Please bring the receipts.
Yeah, I was just trying to think about mechanistically, well, okay, low amount of eggs, but
it's not just low amount of eggs. AMH is reflective of the quality of the eggs. You may have lots and lots and lots of eggs, but the quality isn't so good. And you might become pregnant and it might not go to term. Pregnancy rates after 40, first of all, pregnancy rates after 40 are on the rise.
Yes.
Not because fertility is better, but because women are trying to get pregnant, right? I think. But I think for the first time ever, in fact, women in their 40s are having more babies than teenagers are. Now, that says a lot about public health and cultural norms and birth control and all sorts of other things, right? The thing is, these women are largely perimenopausal. We're going to go off on another route, but I'm really fascinated by this because this whole convergence of fertility, postpartum, and perimenopause is fascinating to me. And people are starting to talk about it. I've been talking about it. Other people are starting to talk about it because now you come in. So right, their AMH, whatever their AMH is, but there are people who are getting pregnant and having babies. Some of them are with assisted reproduction, but they're getting pregnant and having babies. Now they have a baby. Is it postpartum or is it perimenopause? Well, it's both. The postpartum at 42 is not the postpartum at 32. It's not. It's a totally different postpartum. You're 10 years older. Your body is older. You're having all sorts of side effects and, hormonal shifts that are, again, predictable for postpartum, but they're ramped up. Talk about pouring steroids on them. So your hot flashes, your sleep disturbance, your mood disorders, your metabolic changes, your strength. It's totally different. Not here to say don't have a baby at 42, but just like don't have a baby at 42 and not understand that's what's coming.
What you're getting into.
Yeah. And we need to do better too because we need to be like, oh, no, you have a baby. It's normal. You're tired. No, you need a little bit more help.
Yeah, oh, yeah. You need a village, even if you're in your 20s,
yes,
right?
Yes, you do. Yes.
The only reason I went down, and we're going to get off fertility. I just wanted to go down. I know, because I was just so interested to understand if you go into, because we're at the pause event and we're talking, they brought up early menopause due to a number of things. It could be a hysterectomy, oophorectomy, anything. And I was like, that's interesting. And then I thought about AMH and it wasn't clear to me, but it's actually the ovaries itself that's producing. So even if you've got no follicles, okay, I mean, I don't know. I'm going down a tangent just trying to understand.
No, but I mean, listen, I feel like I would like to read more on this too, because it's not well enough understood. It just really, really isn't.
And, I believe you follow your mother so irritatingly, if that's a word. I've asked her several times, what age did you go into menopause?
Yeah.
She tells me she doesn't know. She thinks it was 52.
Yeah.
So I'm like, does that mean I will do that?
I mean, there's some genetics. I think it depends on how much
Never had a hot flash, by the way. My mother never had that. Her sister
I love that
suffered.
For her.
Like her sister, on the other hand, who's 2 years younger than her, suffered immensely. And she's really gone through menopause in terms of the hot flashes and the moods. With my mother,
nothing.
She's like, no, don't know what. No, and she never did. She never had a hot flash. She sleeps perfectly. Never had sleep disturbances. So I'm like, please God.
We're hoping for you for that.
Yeah.
I also think, though, I mean, it depends on how old your mom is too, because there was a whole period of time where menopause wasn't talked about. And I hear this a lot from my patients who are
she's
older.
70. She never went through, she was deprived
but also
of
people,
that.
Exactly. So then people didn't talk about it. Like now everybody's talking about it. So everybody's like really digging in and understanding how they feel. And like they're all in their feelings anyways. It's a different generation. But that generation was also like stiff upper lip. You don't talk about it. Nobody, like there was nothing to do. Just keep going. Hopefully your mom did have an easy transition, and I hope that for you and for everybody. But I think some of this like lack of memory is like, it just was buried.
Can you still, because I got a message on Instagram, I get a lot of messages, and one woman reached out to me. She goes, hey, I just want you to know, I just listened to your episode, whatever one it was. She's like, I've been on hormone replacement therapy, estrogen patch. She's 47.
Yeah.
She goes, and I fell pregnant naturally. I don't know what happened next. And she goes, I didn't know that you could fall pregnant and be on hormones at the same time. So my question to you is, what if a woman you suspect has come to you and she's 39, 40, and you believe she's she's in perimenopause, but she says, I want to conceive. Can she still do that with an estrogen patch on?
I mean, yeah. Do I recommend she do it? I think this is a really good conversation to have, because 39, 47, look, if you're still menstruating, you could still get pregnant. So it doesn't matter what age you are. Like if you're menstruating, you're ovulating. You may not be ovulating the best egg in the world, but you could. So I feel for this person, because I'm guessing she didn't think that could happen. And
she didn't.
I mean, it's always the person who thinks it can't happen that it happens to, unfortunately. I think it's just a matter of what we call shared decision making. So if a 39-year-old comes into me and we've excluded other reasons for her symptoms and she's perimenopausal and she really wants to try hormone therapy, we also have to have a conversation about her sex life and her fertility desires, because that's a different conversation. If somebody is on hormone therapy, specifically on estrogen and progesterone, and gets pregnant, it's really not going to be a big deal. Like if people are doing fertility treatments, they're going to be on way higher doses of that. Testosterone's a different story.
Yes.
So this is why it's really important for people to understand the decisions that they are making and advocate for themselves, right? Because you would hope that a clinician will have a conversation about these things, but unfortunately, we can't rely on that.
It's an interesting era, and I still don't think that, what are the statistics right now? 5% of the population are on hormone
North America.
therapy?
I mean, like they've cobbled that together from like, pharmacy benefit usage. So if you add in compounding, pharmacies, which are not going to be part of those databases, it's probably 5-6%, it went from over 40% in the late 90s to less than 5, like let's say 5%. Not a lot of people using it.
I cleaned up my diet, my sleep, my training, but the last frontier was actually my home. So let's talk about cleaning products, because most traditional cleaners, they release chemicals that impact your hormones, your lungs, even your cognition. And then we bring them into our homes without thinking. This is why I now use Branch Basics. It's one of the simplest upgrades I've made. One concentrate replaces everything under your sink. Kitchen, bathroom, laundry. There's no fragrance in these. There's no endocrine disruptors. There's no headaches after cleaning. You feel better because you know that when you're breathing in the fumes from the cleaning product, you know that it's cleaner for you because there's nothing harmful in it. So Branch Basics, I moved onto this and it's been amazing for me, and you can too. You can get 15% off the premium starter kit at branchbasics.com. Use code NEURO for 15% off. One thing I learned is the way you start your day sets the tone for your entire brain and body. Now, my mornings begin with coffee, yes, and coffee's so good for cognition, guys. I have now been using Bubs Naturals MCT oil creamer in my coffee because it gives me smooth, steady energy without the crash, and it actually curbs my appetite. It blends perfectly. It's made with clean ingredients. You guys know I love that. And it supports brain function by helping your body produce ketones. That's one of the most efficient fuels for cognitive performance. I love the Bubs Naturals mission. It's named after a Navy SEAL and built around integrity and service. And 10% of all profits go to the veteran and first responder foundations, which makes every single purchase even more meaningful. If you aren't on collagen peptides, let me tell you, you have to get on them. Try it for yourself at bubsnaturals.com. Use code Louisa for 20% off. Guys, it tastes amazing, by the way. Why are you so passionate about pushing this movement forward and educating the world?
Women deserve to know about their bodies, and how can we live on this planet and not understand our bodily experience? I mean, that's just like basic human rights. So I appreciate the way you worded that, because I want to push the narrative forward that we have a right to exist on the planet, which seems really basic and may seem like dramatic on my part, but like the narrative has been, you disappear, you are invisible, you go away, it's all bad, frailty, disease, badness, right? You know, just like, please be over there and be quiet. So I obviously don't buy that at all. And I think when we have the resources and the support to get through the experience in the way that we want to get through, a lot of us will be on hormone therapy. I think a lot more of us should be on hormone therapy. Do I think every single woman needs to be on hormone therapy? I think it's up to them to make a decision, as long as they are getting good information. Because I always say this is not informed consent if you don't have the information. But more importantly, if we are resourced appropriately and supported, we can move through this transition and into the best phase of our lives. Like you kind of said it a little bit in a different way, but this, to me, it's the return to your authentic self. That has been my personal experience, and I've seen it happen with many, many, many patients and many women that I interface with online, in events, whatever it is, educating people. There's this incredible sense of restoration, of confidence, of calm, of purpose, of joy, really a liberation from not only your cycle, which, you know, for many of us, it's annoying, you know, or it's disruptive. And I think this idea that like, it is a beautiful part of being a woman, but is it the only embodiment of femininity? Not in my experience or in my opinion. So we kind of have to go through the loss of it and kind of bend our minds around it. And then you're really liberated is the way I see it.
That's interesting.
Yeah. Very empowering.
Yes. Sometimes you feel you can identify as a woman due to your menstrual cycle each month, and that's what makes you.
Right. That's what makes you a woman.
Yes.
And it's like, really? Is that what makes you a woman?
Yeah.
I mean, I think there are many, many, many things that have challenged that notion of what makes a person a woman.
Oh, yeah. Well, of course, what we know now. I just learned that even transgender men can fall pregnant.
Yeah, if they have all their parts.
It's very interesting. And I was like, oh, but so that means that the amount of testosterone circulating in them still doesn't mean that it outcompetes estrogen. And so there's just so much that I'm learning as well that you think, how is this? It's 2025. What's going to be happening in 100 years? You know, I won't be here to experience that. Back to the, you know, serotonin and gut health and women who experience this and they go on SSRIs. It's interesting because you see that people who fix their gut. I don't know if you've experienced this, because I know you've done a lot of Ayurvedic medicine.
Yeah, no, I'm trained in Ayurveda. Yeah.
Very, Western medicine, board certified, and then Eastern medicine, I believe, is Ayurvedic. It's interesting to see that somebody who's trained in both. What do you learn about healing the gut when it comes to depressive-like symptoms?
Well, I mean, again, this is a complicated story, but we now know that the gut is the seat of the majority of our neurotransmitter production and our immune system production. It's very, very much a modulator and regulator of our metabolism. It has a huge impact on hormone production. In fact, there is a part of the microbiome called the estrogen. So we know that estrogen is recycled and reabsorbed and transmitted largely via obviously it's the gut itself. So gut health has a huge impact on our overall health. Ayurveda, which is the ancient Indian medical system of the subcontinent of India, there's many principles, but the primary principle in terms of health is gut health, this idea of something called the Agni, or the digestive fire. So, and the earliest texts that are medical texts that exist on the planet are Ayurvedic texts. Conservatively, 2,000 years old. It's probably older than that. Chinese medicine and Indian medicine grew up around the same time. There are a lot of similarities, some differences, but the earliest texts that exist, I believe, are Ayurvedic texts. It's so interesting to me that these ancient healers understood the gut and the impact of the gut on the mind and on every other aspect of the body well before we could slice and dice and use an electron microscope and name all the different microbiome components and understand, that the villi did this and the immune system is that, and blah, 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 blah. So, and now we're catching up with that. I always find that amusing.
Well, how does...
Amusing. Now we're proving it. Now it's real.
How are we proving it?
Well, I'm saying because we have huge labs devoted to these things, and now it's real.
What's the crossover between menopause and Ayurvedic medicine? Because I was going to say you can't supplement your way out of menopause.
Oh, no.
You can't think your way out of it.
No.
So it's definitely a certainty for all women.
Yeah. If you're alive, if you live that long.
It is death, taxes, and menopause. Right?
Right. And maybe not even in that order.
Exactly. Oh my gosh, don't scare me. Why the interest in Eastern medicine?
Well, I had done yoga, on and off as a young person. I came out of my medical training. I had 2 small children. I was starting my practice. It was a very exciting but stressful time in my life. I actually met a person. I mean, the story is this. I met in my senior year of my residency a patient. In the clinic, you had your patients. This person she needed a hysterectomy. She had huge fibroids that were like, I've never seen such big fibroids in my life.
What centimeter?
Oh my God, they were like, I'm telling you, it looked like 47-week pregnancy, which isn't a thing.
Oh my God.
Like humongous. And she was a teeny tiny lady, right? She'd tried everything. She was not my patient in the clinic. The way the structure worked was you had your clinic patients, and I was the chief resident on the surgery service. And so my junior resident said, hey, okay, I got this patient. This is what we got to do. Okay, we're doing a hysterectomy. Fine. I meet her the day of surgery. I don't even know this lady. I go into the pre-op area to introduce myself, say, hi, how are you doing? We're going to do this thing. You're going to be fine. Whatever. Like, be a nice person. I meet her and she says to me, listen, I've got these essential oils and I'd like to put them on you to help you have clarity in the operating room. I was like, go ahead, bring it. Absolutely. I mean, I'm thinking like, what the fuck? But I was like, listen, this lady literally met me 2 minutes ago and I'm going to cut her open, stem to stern. She wants to put some oil behind my ears. I could
do what you need.
Yes, like let her feel safe. My Lord. She didn't even know me. That's that. We do the surgery. I'm telling you, it's almost 30 years ago. I remember the surgery. It was one of the most challenging surgeries I have ever done. The next day I go see her post-op to check out, we're rounding, I'm seeing her. Her room has Tibetan prayer flags. It does not smell like a hospital. All her friends have brought food. She's got beautiful soup and she's recovering and she does great. She has a huge incision. She recovers so rapidly. Everybody kind of wants to be in the room. The nurses want to go. Everybody's like, what's happening in here? The vibe, there's a vibe, right? So I must have seen her post-op in clinic or something, and she pulled me aside and said, look, I want to thank you because you did me a kindness and I really needed it. And what you didn't know is that right before you walked in, your attending physician, who was this amazing but very conservative Southern gentleman, had come in and she offered the same thing to him and he kind of balked. Like he was surprised. He was like, oh my God, I'm in LA. What is happening? Right? We're not in South Carolina anymore. And I didn't know that. And she said, I really want to let you know I appreciate that. And I'm giving you my card. I teach Pilates and yoga and meditation, and I would love to give you a gift. And I was like, that is so nice of you. Boundaries. Thanks, but no thanks. But thank you for letting me know. I'm so glad you had a good experience. I was graduated, had my second baby, about to have my second baby, cleaning out the room that was my office was going to become my new baby's room. And I found her card, and I had now finished residency. I was like, oh, I'm not a resident anymore. And I'm really stressed out. I'm a stressed out mom I'm going to have 2 kids. What am I doing? I need to calm down. So I called her and I did Pilates with her. And then she ended up teaching me meditation. And then she one day said to me, Ayurveda, I think it's for you. Literally. And I was like, what are you even talking about? She's like, I think you should study Ayurveda. And I was like, what is Ayurveda? And she's like, go check it out. I started looking into it and I started reading it and I was like, this is so interesting and fascinating. And anything I could find, I would go to a talk. Ultimately, I went to the Chopra Center. Deepak Chopra was still teaching physicians at that time. They had a program for healthcare practitioners because they knew, smart, doctors aren't listening to anybody else. They need to hear it from a doctor.
Yeah.
And I went down for a week and my mind was blown. And I was like, this is what I'm missing. I loved medicine. I loved conventional medicine. It's a miracle, but something was missing. The spirituality was missing for me. The healing energy that I knew was being transmitted back and forth, by the way, because we receive quite a bit from our patients if we are paying attention. It wasn't enough for me. And I was super curious. So I decided to pursue it really for my own benefit. I wasn't like, oh, I'm going to now be an Ayurvedic practitioner. Ended up doing a really serious course of study and an accredited institution and an internship and making herbs for my patients. And I mean, a whole, while I was doing my conventional practice, this encounter changed my life, changed my career, opened up so many doors. Microbiome, all this stuff. I've been into all this stuff for a really long time because Ayurveda helped me think more critically and on a bigger picture level about stuff, and also gave me different tools, right? Like looking at the history of how humans interact with healing tools, how we interact with the environment, how the local seasonal rituals impact our health, how we impact each other's health. Even though I continued to practice conventional medicine, and I still do, I just thought differently about all of it. Much more interesting for me.
That is because as I'm getting older and experiencing all new things, I keep, and obviously reading Instagram quotes, I think to myself, are your thoughts really making you feel a certain way?
Oh.
I'm going to post a reel tomorrow. I found amazing data, an amazing study on negative thought pattern thinking and Alzheimer's disease.
Oh, wow.
Yes, and it wasn't a correlation study. So and that was very interesting to me. And I thought to myself, is this because of maybe the elevation in cortisol? Maybe you can trick your brain. What we know in neuroscience is when neurons fire together, they wire together. So can your negative thought patterns really convince your brain that you are perceiving whatever it is that you've concocted in your head, which is raising cortisol, which is inducing neural inflammation and leading to neuronal death? Is that the pathway? Have I gotten it right?
I think you have gotten it right. And I think we don't completely understand all of it yet. And, kind of getting back to estrogen. Estrogen in its sort of sweet spot is anti-inflammatory. And that's one of the reasons that, I don't think I know we don't fully understand what is going on in perimenopause that is setting some of us up for dementia and Alzheimer's specifically, because it looks like, honestly, it's not just the loss of estrogen. It's something that's going on in perimenopause.
Yeah.
And that up, down, unpredictability, you're getting very, very high highs and very, very low lows, both of which are inflammatory. So it's kind of like a soup,
state,
right? It's a soup of inflammation. And that would really, to me, that is intellectually appealing. I don't know what the data is.
It is.
But what you're telling me absolutely makes sense, because it's it's just like another log on the fire.
Yeah. Well, it kind of reminds me of hypertension,
Yeah.
right? You know, what we don't want to see, which is quite interesting because the data from the SPRINT study literally is like, you must be 120/80 as gold standard. And it's like, yeah, well, I'm 130/85. Yeah, no, that's bad, because then that's when you start actually killing off the capillaries in your brain. And we know that even fluctuations in glucose, you don't want to be like this. You don't want to be like this.
Yep.
So it's kind of similar with perimenopause.
Well, but so you're getting all of those things, though, right? Because you're getting estrogen impacting the vascular endothelium, and you're getting more stiffness, right? So you're getting less oxygen flow. You're getting
Nitric oxide,
right,
yeah,
100%. So you have the glucose metabolism piece. You have the loss of sleep, the increase in stress, and all of those neurotransmitters. So, I mean, look, like, hello, you're lining all these things up that are like pushing you toward, now you sprinkle in some genetic predisposition.
Yeah.
So again, I don't.
And lifestyle events
Oh my God.
that happen, like what
Stuff
I
happens.
go through now, it's like, I remember my 20s. I'm like, oh my God, I was skating through, you know, like I was so dumb. I don't know, maybe just so naive compared to like what you know now.
As the person that you were at that time.
Oh, I love that
Be
you
nice
said
to
that.
yourself.
Okay, so there's something about what you wear that really shapes how you feel. I didn't know this until I started looking deeper into my fashion and my clothing. And I started to mix things up, but I stopped, wearing fancy clothes at the gym because I didn't think that it really mattered until I turned to Viore. I'm such a huge fan because their dream knit fabric is unbelievably soft, like a version of comfort that your brain instantly recognizes. I wear their joggers for travel. Guys, I travel like every 3 weeks and I hate it, but it's so much better being able to travel in Viore. So if you guys want clean products, you want to look good, and you want comfortable clothing where your body feels supported, well, turn to Viore. You'll get 20% off your first purchase if you go to viore.com/neuro. That is VUORI.com/neuro. All right, so let's talk about liposomal glutathione. I know you guys know what glutathione is. Raw Nutrition has probably the best form of liposomal glutathione. Their liposomal delivery system helps your body actually absorb antioxidants like glutathione. They also have an NAD1 and curcumin. And what happens is when it goes in liposomally, it actually absorbs better because it doesn't get destroyed by the digestive tract. So their liposomal glutathione is something that I've personally been taking. I love glutathione. If I do it with an IV, I do that too. I really, really love it. I do it every single week. But then I found out that Raw Nutrition actually has them in liposomal form. Now, let me tell you something about glutathione. It's the master antioxidant. It's the thing that your cells rely on to neutralize free radicals, support detox pathways, and protect your mitochondria. So when glutathione levels are strong, everything from energy to mood to skin clarity even improves. And this is the first form where I've genuinely felt a shift. If you want to look at it, you can go to rawnutrition.com, use code NEURO to get 20% off. Just go to rawnutrition.com, code NEURO to get 20% off. So a woman comes to you at 37 years old and she's on an antidepressant because she was seeing a fluctuation of these. You do a blood test. Her blood test comes back as normal for estrogen, progesterone. She's menstruating every 28 days.
Right.
Fantastic.
Right.
But she's irritable. Maybe she's getting rage. She's very stressed at her job.
Yeah.
What do you do?
I mean, it's a conversation. So first of all, thank you for bringing up the labs, because the fact that labs are quote normal is not meaningful. I mean, first of all, what day are you checking the labs on? What did her labs look like when she felt her best? I mean, we don't know any of these things yet. We don't have real reference ranges for anything other than fertility, to be honest with you. So, I mean, I'm not mad at checking labs. I'm mad at checking labs for no reason. And for people either using them as a tool of dismissal, your labs are normal, fine, bye. Or, we need to replace every single thing. Look at your labs. Like, that's not a thing. Like, you made that up. Okay. Please, again, show me the receipts. There are none. So, but yes, we've checked. There's nothing else going on with her. I mean, It depends. Did she just get thrown on the antidepressants? Which again, not mad at antidepressants, just like if you don't need antidepressants, then you also need hormones, maybe we should be talking about that. The way I assess somebody is I ask them to, if they haven't tracked cycles, to track their cycles and their symptoms. And when there's an obvious pattern that where they're peaking in whatever the symptomatology is, mood, whatever it is, around ovulation and again premenstrually, or often what will happen is from ovulation on, they feel bad, they feel different, they feel off, they're not sleeping well, all those things. That to me, that's perimenopause. And that's where I can dig in and look at stuff. And some people I just put on progesterone the second half of their cycle. Some people I do estrogen and progesterone. It depends on the person. It is never one size fits all. I just had a person today who I did a follow-up with who came to me really feeling like that, just feeling really, really bad. And I started her on luteal progesterone, and she was having hot flashes and stuff too. So I put her on a low-dose estrogen patch, and for 10 months, she's done well. Today, she's starting to skip her periods more. Things are different. It's hard to track. So now we made a change. So my point being that things are going to continue to evolve. This is an ongoing conversation. There isn't like, this is plan A and this is plan B and it's followed by plan C. And now here's the protocol and everybody does it. No.
That's why you've got to have a good relationship with your practitioner. Yeah. Someone who knows. It should be a board certification.
Oh, yeah. I mean,
Is that what everyone's lobbying against?
Well, no, I don't think anybody's lobbying against it. I think we have, the politics around the OBGYN training and how we're going to deal with this are a little bit intense. The fact that we have a 4-year residency that is devoted to all things pregnancy, all things birth, gynecology, office gynecology, physiologic changes, reproductive endocrinology. The specialties have fellowships. They have 3 more years. OBGYNs are not training. They are training hard. Anybody who's doing cancer care, they're doing an additional 3 to 4 years. Anybody who's doing minimally invasive gynecologic surgery or fertility or maternal fetal medicine or urogynecology, they're doing additional years after that 4 years. But for those of us who are generalists, we're supposed to be doing everything. I really think there's going to have to be a come to Jesus about how we're doing this. I think you're right. And I think the comprehensive nature of, midlife women's health, because it's not just about the hormones. It's about the brain health. It's about the bone health. It's about the heart health. It's about the mental health. It's about the sexual health. And honestly, all of our lives should be that way. At 25, we are all human. We're whole human beings. Yeah. And I think we have to figure out what our path forward is.
No one has actually taken women in their 40s and 50s into consideration when it comes to this then.
We fall by the wayside because the high ticket items and the really dramatic changes are the things that we're getting we're focusing on. And then there's a horrible problem with reimbursement in this country too. The way we pay for medical care, the way medical care gets paid, it's not paid for.
Oh, don't I know it? I'm Australian.
Power. Oh my God! Right, this is time consuming.
Yeah,
this is time consuming.
Oh yeah.
So the way it's reimbursed now is volume based. You can't do this in 5 minutes. You can't do it well in 5 minutes.
Oh, absolutely not.
No, of course not.
I think that's why a lot of people are opting out of medicine as a career.
Oh yeah.
Yeah.
Which is terrible.
Oh my God.
And sad.
Yeah, I've had would you call it a come to Jesus moment? So I've shifted a lot of what I do for a living. I've now gone straight into Alzheimer's disease and women. And prior to that, which was in my 20s, I was very much human performance and peak brain health and this. And I'm getting a lot of messages lately. Why have you given up on men?
Oh.
I'm sorry, but you go through our version of menopause in your 70s. You've got enough testosterone and estrogen, because testosterone is aromatizing into estrogen during your 40s to protect you from these debilitating diseases.
Yeah.
What I know in Australia, so my dad is 72, and I say, have you done your PSA score? And a lot of times even men are getting pushed off, at the age of 70. We don't need to check PSA scores. And I'm like,
who cares?
Yeah, who cares? And I'm like,
because the message is, who cares, you're going to die.
Yeah, who cares if you get it in your 70s? Yeah.
But I distinctly remember being taught that way in medical school and in my training about testing of all sorts for men and women as they get older. We do not value aging. We do not value the wisdom that is inherent in people who have been on the planet longer. It's just like so messed up.
Well, that's because historically evolutionarily we died after reproduction, 35, 40.
And that's why the like people who did live were like the elders and the like sages, right? Because there's like 4 of them. But, but like that's not how it works now. And I just think we can do better. And I don't know, my attitude about this is like, I'm not really so interested in fighting about it. My feeling is I really do think that, some things make me mad. I think some of this is postmenopause. I'm like, you know what? I'm like fairly chill. People who know me like are like, I'm pretty intense. You can imagine how I was before.
I love it.
But I don't get as riled, and my attitude is like, I will be over here with my wisdom. If you would like to partake, I am happy to share it. And I will show up at your thing, and I will write a book and all those things.
Yeah.
I will show up. But like, if you don't want to hear what I have to say, that is literally your loss.
Yeah.
Really. So, I've pulled out, like I am in my own practice now where I do what I do. I have membership. I have lots of time with my patients.
Oh, I love
I do
that.
a lot of free education online.
Oh, yeah.
I gave at the office for 26 years, but if you, and a lot of what I do is preventative care because I'm very interested in longevity for myself and for my patients. And what's so interesting is that people are coming in much earlier. I'm talking in their 30s saying, okay, the writing's on the wall. I know what I do now really is going to matter. So when you talk about like performance and longevity, if you don't address perimenopause and menopause, you know this, what is the longevity for women? It isn't there. And it's, again, not just the brain health. It is our bone health. It is our metabolic health. It is our heart health. So it's very exciting to me that people are starting to get that message and they are asking for better care and they are asking for prevention. I had a really interesting experience. At the end of last year, I had a patient, because I always advocated for my patients and I always taught them to advocate for themselves. So I had a patient who was in her early 50s, perimenopausal, and she kept going to her primary care doc, asking for this, asking for that. Because I was like, hey man, did they do this, and this? Like, just ask them to do it. They don't even have to think. You can just ask them. And she told me that her doctor was clearly getting annoyed by this. And she, to this doctor's credit, sat her down and said, look, I think you're looking for health care. We provide medical care. Oh. Wow. Which I really respected because she said the quiet part out loud. Yeah, we're not going to prevent your diabetes. We'll treat it when you get it. And this woman had already decided like, this is not the place for me. And this is a doctor who I think is really well trained and works for a very large academic institution and needs to see 30 patients a day, I guess, and just, that's not their algorithm. That's not their protocol. I'm not here for that. That is not what I want to do as a physician. That's certainly not how I want to be treated as a patient. And when she said that to me, I'd already made the decision to make the move that I was making. And I was like, holy crap, this is exactly the system that I don't want to be in there fighting it. It's not going to work, in my opinion.
It's going to take years.
They don't have the will to do it.
We have gone absolutely everywhere. So I may as well bring it up. Peptides.
Yeah.
So, let's just talk about the biggest elephant in the room, GLP-1s. I am very for them because I think that they're doing great things in all different ways.
Yeah, I agree.
I'm very, I put that out there on social media.
Yeah.
I don't think you should abuse them.
Well,
I don't think you should get them on the black market, wherever, I don't know. But I think it, when taken, I think they're doing phenomenal things for the brain, breast cancer reduction, obesity, type 2 diabetes.
And when you use them with hormone therapy, they're even more, the synergy, there's data on that now. The synergy,
really?
In terms of reduction of heart disease, markers, diabetes improvements. Oh, yeah. So, I think the brain stuff is going to be amazing.
Oh, yeah. I'm excited about that.
Me too.
But let's talk about other ones. Some of the most popular ones, I don't know if are you prescribing?
I do not.
Peptides?
I do not. Like, I'm super peptide interested, but I feel like prove it. Like, what is going on?
Yeah, the most popular ones right now are combining TB500 with BPC 157 to create this, I guess, angiogenic effect. So you're getting, which is the TB, but TB500 is putting people to sleep better into deep sleep. But then you're getting BPC 157,
right, and people are
which
using
is
that for like recovery and
eliminating
working out.
DOMs. Yeah. And I think that would be great. But then there's like Ipamerol. I don't know. There's all
there's a bunch. Sermorelin is the one that I'm hearing a lot about.
And I'm like, okay, and I've got a lot of friends who have gone to these clinics, and I'm really interested in what it can do.
I am too, but I have a lot of questions, right? Yeah. So the problem is anything that will have any kind of growth hormone implications, we have to be really careful about. And I think the problem here also is the level of education with the public and from the clinicians, because it is really under the radar, even though everybody knows everybody's doing it, especially in LA. Oh my Lord. But it's, what I think patients may not realize is that this stuff is not approved for human use. Like literally, if I wanted, let's say I want to start doing prescribing peptides in my practice, right? Not the FDA approved ones. I have to actually order it in powdered form from the lab, mix it myself. Yeah. So it's like a whole mad scientist situation. And I'm not saying that cutting edge technology and science doesn't deserve to be offered to the public, but I think we need to be a lot more upfront about like what we know and what we don't know. We don't have large safety studies in humans that I know about. And I'm trying to just keep up on the literature that I'm trying to keep up on, and I can barely do that. So I haven't really done a deep dive yet. I have a colleague who I really, really trust who's sort of moved into that world. And literally she and I were texting about this yesterday. And I said, look, I want to learn more. I want to hear more, but there no way, no how is this going to go into the hands of any of my patients until I am convinced. Like I need to see the data. I need to see that it's safe. Period. End of sentence. I mean, this is a doctor who actually said, I'm a breast cancer survivor. And I had come to her and I was like, hey, these are the things that's going on with me. This is the hormones I'm taking. What if you were going to do peptides with me, what would you do? And the first thing she said was like, okay, Suzanne, you're a cancer survivor. So all of these, like the two, the
angiogenic ones,
they're all off the table. That's a big no.
But is BPC 157?
That is too.
Oh, I didn't know that.
Yeah. That's what she said to me. I'm an early adopter about a lot of stuff, but not everything.
Of course.
I'm way more comfortable with herbs. That's my background.
Yeah.
Way more comfortable. And there's, as much as the data is missing, like we don't have these large clinical trials usually, there's way more data in humans on a lot of this stuff. So
we'll see.
It's definitely, it is the wave of the future. For sure.
What would you say to just to close off, 37-year-old, she's heard that the perimenopause transition, she doesn't know anything about medicine. It might happen in 3 years. What are you going to tell her to prepare for it?
Let's reframe the narrative around this as not a fearful, terrible situation. It's going to be another change, like you had mentioned, and I use this term all the time. It's, some people are calling it puberty in reverse. I call it the puberty of midlife. It's yet another physiologic phase. So first of all, let's not be so scared about it. It's really not going to be terrible. Second of all, I think a lot of it is where are you now in terms of your personal, professional, and health goals, and where do you want to be? Because to me, it's such a beautiful opportunity in your 30s as you're facing inevitable changes to look at the foundation. There's no amount of hormone therapy that I can give anybody that's going to fix everything. Because if you don't have the foundation of, nutrition, movement, including strength training, sleep, stress, social connection, spirituality, I can't do anything for you. You know what I mean? Of course I can. I'll write you the script. But the foundation is everything. I can't put a house of cards on top of a crumbling foundation. That's not happening. So they need to go hand in hand. And that also includes giving yourself some grace, because there isn't a perfect way to do it. I know protein is our second career now, and everybody feels like they're doing everything wrong, and that it's going to change in 5 years. I've seen trends come and go in my course of my career. But I think just understanding this as an opportunity and seeing it as an opportunity to get to know yourself, get to know what are your vulnerabilities. So I'll tell you what I do when you come into my office as a patient, and that will help you understand my process. Obviously, I get all your history, including who are you? And the great thing about having an hour is I kind of can really get to know who you are in some ways. body composition testing. I start with body composition testing.
Bone mass, bone mineral density.
Yeah. It's because people often are very surprised. They think it's better than it's going to be. They think it's worse than it's going to be. And then I do lab work. I do biomarkers. I don't go too crazy, but I do look a little deeper in some lipid stuff and some cardiac markers because I feel like that gets ignored. I'm now offering micronutrient testing, and that's really a reflection of gut health. So I'm really trying to get data on you. Where are you right now? Okay, you think it's this, that, and the other, but in fact, you're vulnerable in this area and that area, and you're much stronger in the other area than you realize. So let's capitalize on your strengths. Let's optimize those strengths.
Green, yellow, red flags, triage them.
Yeah. And we have a path forward.
I think biomarkers and lipid panel is really interesting because I didn't know this because I'm so deep into this world. I didn't know that regular physicians aren't testing ApoB, LP little a, which I think is...
Those two alone. Can I tell you how much I've picked up?
What? Yeah. What's your cutoff for ApoB?
Well, ApoB, first of all, ApoB is going to vary with the LDL, but 90. About 90.
That's your cutoff?
Yeah.
Great.
Lipo-A is, I'm telling you, I've had people come in with Lipo-A that is like twice the normal. My reference range with my lab is under 75. And I have seen people who their body comp looks good, and they know, well, my dad has high cholesterol, my mom had a stent, that's already a red flag for me. Your mom had a stent.
Yes.
But, and I've had more than one person who I have sent to the cardiologist, and we've discovered stuff early. This is going to change the course of her life. She's not going to have a heart attack at 52.
Yeah.
And I mean, I'm sure you've seen this data that like around 50% of women who die of sudden cardiac death had no risk factors. Oh my Lord.
Yeah.
Stop it.
Well,
you weren't looking.
Doesn't it
actually?
You
weren't looking.
Yeah, exactly. You weren't looking. A heart-related event in females triples at the onset of menopause.
Yeah.
And that's because of loss of estrogen, LDL goes up. That's what we see.
Yep.
And that's actually another biomarker during perimenopause, right? You could see.
Yeah, you start seeing these subtle rise, and a lot of women also, insulin resistance starts to happen. So you may not see changes in the insulin level itself, but you'll rising fasting blood sugar. They'll have a totally normal A1C, but the fasting blood sugar is going up. So there's like subtle things, and these are things that we can act on. So that's the thing. Like if you have information, you can change the course of your life and you can increase your health span. You can decrease frailty. Like it doesn't have to be bad.
No, I know. I say this every day, like data is king. If you don't have this, how do you know what you're optimizing for?
I'm with you, obviously. I mean, the data is so interesting. It's so illuminating, and it's your friend. It's not like, okay, bad test, bye. No. Then we're going to look at like, well, how are you eating? When are you eating? What is your sleep like? What is your stress like? What are the things that you're doing? Oh, that was the thing that really worked for 37-year-old you, but for 47-year-old you, it doesn't really work anymore. So how do we tweak that? How can I support you?
Well, we're going to link your practice and how people can come and see you. I'm sure you're phenomenal. I want to come and see you. I want you to work on me on every aspect. That's my dream one day, to have a board of directors for every area of my life. I mean, talking physiology, a board of director for Louisa's brain, board of director for her body, bone health. But Dr. Suzanne Gilbert, thank you so much for being part of the Neuroexperience podcast.
Oh, it was my pleasure.